Sure, these are the 3 minutes that we gave ourselves to start the session. You're welcome to this webinar. My name is Dr.Mondo Desmond Benjamin. I'm the head of communications at Busoga Referral, and we are always humbled that you are here every Friday to join in. At this juncture, we're having our presenter ready. We're having our moderator, Mr. Samuel, who will only do one role to introduce the presenter for today, and then he'll be going into another meeting. At today's session, we shall be talking about the Rhesus incompatibility by Dr. Mondo, who is a gynecologist at Jinja Regional Referral Hospital. Before we go into this session, I just want to give you a brief highlight about the Busoga Referral. Busoga Referral is a non-government organization which is located in Jinja, and our mandate is to improve the health of the people in this region. Samuel, are you talking something? You're unmute.
Yeah, we can hear you.
Okay, yeah. So our mandate is that we improve the health of the people in Busoga, and we work through members. So we are a membership organization, and we encourage everyone who is here to become a member of Busoga Referral, such that we can elevate our work and we can reach more people in this region. Every Friday we have these webinars. This is one of our activities that we do, and we aim at improving capacity of the health workers in the region. Everyone is encouraged to become a presenter, and we ask you that if you want to make a presentation, kind of reach out to me. We can schedule presentation. At this time, allow me to invite Samuel to introduce the presenter for today, and then we dive into the presentation. Thank you so much. Samuel Kasiband, are you with me? Okay, it's fine. Thank you so much. Our presenter for today is, hello?
Yes, we can hear you.
Our presenter for today is Dr. Mondo, David Bentley, and Dr. Mondo is a gynecologist at Jinja Regional Referral. He has the blood transfusion service at the hospital, and Dr. Mondo is also a member of the Busoga local maternity and neonatal systems, and is doing out of great work to improve issues related to maternal and neonates within the region, and is a member of Busoga Referral, educating of Busoga Referral. And today he's going to make a presentation to us, and I kindly ask him to take over. Thank you so much, Doctor.
Thank you, Desmond. I go by the name Mondo Ben David. I'm a qualified obstetrician and gynecologist attached to Jinja General Hospital. Yeah, I'm the leader for a blood transfusion committee, and also as the deputy head in the department of OBGYN here, and also secretariat when it comes to Busoga LMNS, that is putting MCS services at the forefront. Thank you, members, for joining this session. I will be looking at the RH incompatibility, that's Rhesus incompatibility, which is quite common in this region. And we have lost quite a number of babies, let me say pregnancies, that have ended up with unwanted outcomes, just because maybe some of us are not well versed with this topic, or we have not managed patients before who have this condition. Today, we shall look at what it stands for, how do we go about it, and this has been sponsored by Rockron. We shall see this company, and that's their brand of the anti-D that we'll be using to manage this condition. And I think it's what is being stocked in government hospitals. Maybe I'll be corrected later on. So we shall begin by looking at the Rhesus factor. Rhesus factor, this is it's a blood group system which refers to the 5 main Rhesus antigens, where you have the C, the small c, the D, E, and then the small e. But we know out of those 5, the most significant one is the D antigen, which is serious here. Although the rest are there, but they are less frequent. The term Rhesus factor or RH factor is, it means like a protein that is tagged. It refers to a protein that is tagged on the the erythrocyte cells. It's like a signaling protein. So, which refers to the RHD antigen only. Individuals either have or do not have the this factor or the D antigen. Those who have are positive, and those who do not have this antigen, they are negative. And this is tagged on the surface of the red blood cells, erythrocytes, like we see. So when we look at the Rhesus incompatibility, we mean this refers to the, okay, to explain more, this refers to the discordant pairing of maternal and then the fetal RH types. Like we said, the mother is negative, then the fetus is positive, just like we see here. You have the mother being negative, the father is positive, then 50% of this, the 50% of the chance is that the offspring, that's the baby, will be positive. And where we have the mother who is negative, and then you have the baby who is positive, then now we have the incompatibility setting in, like we shall see. The fetal red blood cells are separated from the mother saturation, we know, by a thin layer of cells, which we call the trophoblast. Remember, we have the syncytial trophoblast, and then we have the cytotrophoblast. So we have the syncytial trophoblast, which attacks to make the placenta embed into the uterus, to make the embryo embed into the uterus, hence creating the placenta. So we have that separation, which is a bit thin and porous. So meaning cells can easily move in between those layers, in and out. They can join the mother saturation, at the same time join the baby saturation. Once these cells reach the mother saturation, they are perceived as an antigen because this mother is the RH negative, meaning it doesn't have the D antigen. But remember, the cells that have crossed to go to the mother are RHD positive, meaning they have the antigen tagged onto their cell membranes, so which is going to provoke an antibody response from the mother. We know that the hallmark of this RH factor and the incompatibility will end up into giving us two scenarios, or the spectrum of hemolytic disease of the neonate, which ranges from self-limited hemolytic anemia to severe hydrops fetalis, like we are going to see. So we have the first pregnancy per se may be safe. Because why? Why is it safe? We see that the mother has not been sensitized enough to form a lot of antibodies that may reach a level where they can easily cross the placenta and cause these effects I've just talked about, hemolyzing the fetal blood cells, giving us the hemolytic anemia, and then the severe form, which is the fetalis, the hydrops fetalis. So in the first pregnancy, where there is no much exposure, this might be okay, and the mother might get away with it or the baby. But then the subsequent pregnancies that come, if the first was not given, if this mother was not given anti-D during the first pregnancy, now this is blown out, like the response is a bit mega, in that now the antibodies will be much and they can easily cross the placenta to attack the babies or the fetus's red blood cells, causing those two conditions. So it is important that we take lead in trying to diagnose or triaging, or we try to evaluate a couple before they get pregnant. That is taking them through the preconception care, where you have to do the blood typing. It's very important, though many times we skip that aspect, but in the end, we end up exposing these mothers, and by the time they come to us, it is too late. Like we shall see, there is a time where this anti-D is functional, or it is useful, and then there's a time where giving it is a waste of time when the mother has already formed what? When the mother has already formed the antibodies, like we shall see later. Before I speak about this, there is the theology, like we previously mentioned, maternal sensitization occurs in the Rh negative mothers due to the exposure to the Rhd antigen. This typically occurs when the Rh negative mother is carrying an Rh positive fetus or has been exposed to the Rh positive blood differently. For example, however, maybe if this exposure to the Rhd antigen occurs during the mother's first pregnancy, we say the adverse consequences of the Rh incompatibility do not typically affect the initial pregnancy because the fetus often is delivered before the development of the antibodies, like we said. So once this mother has been sensitized, then the future pregnancies are at risk. So we said, for example, we have, how do you know that these are dangers of HDN? You have before birth, there will be antibodies, which will cause destruction of red blood cells, and that will lead to hemolytic anemia, reduction in number of red blood cells. Then you have now the gross picture, where you can have like the heart failure. In this fetus, you'll have pericardial effusion, you'll have pleural effusion, you'll have ascites. All those are features or signs of hydrops fetalis, and which is very incompatible with life. 50% mortality rate, more than 50%, which is quite high. Then after birth, you can have antibodies cause destruction of red blood cells. The anemia I've talked about. Sometimes they could have jaundice or buildup of bilirubin from the destruction of red blood cells, which was in utero. Now it becomes evident. You have jaundice, you can have hepatomegaly, enlargement of liver, splenomegaly, enlargement of spleen, kernicterus, where parts of the brain and spinal cord are infiltrated with bilirubin. Then you have severe retardation and then heart failure. This could be in cases which is not severe, and this baby gets a chance to be born alive. Maybe you could see the spectra of syndrome, of symptoms and signs, but later they could complicate, and also we have this baby losing her life or his life early, being a contributing factor to early neonatal death. So there's this aspect of FMH, which is fetal maternal hemorrhage. This means the amount of blood passing from the fetus to the mother at a particular time t during the uteroplacental life. Because there's the uteroplacental or a placental fetal unit, which is concerned with making sure that this baby or the fetus is able to receive nutrients, is able to have the byproducts or the waste products excreted across the membranes. So during that exchange, there is some blood that is able to escape or to exchange between the two the barrier across the two saturations. And this blood is the one which is responsible for triggering this process. If the fetal blood cells cross this the barrier and go to the maternal saturation and they possess the D antigen, and then the mother does not have, so this mother is able to mount or provoke an immunogenic reaction and is able to form antibodies against these cells. So how do we measure this blood? This is done by the Keller-Bach test, AKB test, which we use. Can you hear me?
Yes, Doctor, proceed. We hear you.
Okay, thank you. So we can use the Keller-Bach test to measure how much of this blood has gone or has been exchanged across. So this is a common occurrence, most often associated with small volumes of blood transferred across the placenta, like I've just mentioned. Fetal maternal hemorrhage leads to sensitization of the RD negative mothers, resulting in an increased risk of hemolytic disease of the newborn. Then you have fetal maternal hemorrhage can be calculated using the Keller-Bach test. The formula for the test I think it is in front. So like we said, positive screens can be confirmed with, first of all, before you do the Killback test, there is a test you have to do, which is with the assessment can be done with the Rosette test for screening. And once the screening test, the Rosette test is positive, that's when you go ahead and confirm it with the Killback test or the flow cytometry to determine the percentage of fetal blood cells based on detecting fetal hemoglobin F in the maternal saturation, and then the next steps in management will come in handy, like we see. So if this patient, this is her first pregnancy, surveillance of maternal antibodies is a recommendation. The titers, we have to follow up the titers of these antibodies because we know there is we have the gestation weeks where we know that for example here 3% of pregnant women have FMH in the first trimester, 12% in the second trimester, and then 45% in the third trimester. So we have to be giving the first dose at around 28 because we know 28 that's the second trimester. So we know that 12% at risk, but rare should we give in first trimester unless there has been maybe trauma, maybe this mother has had an abortion or early pregnancy bleeding, where you suspect that there could be some significant amount of blood that could have crossed. But remember, before doing that, you have to measure, then after the Killback test to measure how much, because you drug does this patient need so that you don't underdose your patient.
Well, doctor, we a bit, okay, we're now with you.
FMH.
Well, doctor.
Because hello?
Okay, you're back. We had missed you. You can reshare your screen.
Can you see my screen?
No, you can share it again. It's off.
Oh, sorry. I think there was some interruption in the network.
Sophie, could you unmute?
Is it there now?
Yes, doctor, it's back.
So how do you take care of these silent fetal-maternal hemorrhages that do have, now we are looking at the drug we are using, because we have seen how this incompatibility comes into place and how the allo immunization takes place and the consequences if it's not managed. So how do you treat? So we are looking at the treatment. How do you deal with the silent fetal-maternal hemorrhages? We say that a single injection of 300 micrograms of anti-D at 28 weeks gestation provides protection for 12 weeks. A further injection of 300 micrograms within 72 hours of delivery of this RH positive infant will protect most immunized RH negative mothers. So here I have two opportunities to help this woman. At 28 weeks, This will confer protection for 12 weeks, and then also later, postpartum within 72 hours, which will be able at least to add more protection to these mothers who have been exposed and they have these RH positive infants. So this is known as the postpartum prophylaxis. However, we know that 300 micrograms of anti-D will neutralize 1 ml of positive, no, we neutralize 15 mils. It is 15 mils of positive cells or 30 mils of blood. It is 15 mils of positive red blood cells or 30 mils of blood in the maternal saturation. This happens in the maternal saturation. That's why you're giving your anti-D. So it will neutralize 30 mils of positive red blood cells, that is from the fetus, or 30 mils collectively of blood in the maternal saturation. So what is this anti-D? We know that anti-D is an antibody against the epitome present on the fetal red blood cells, so as to prevent the Rh negative women from sensitization. So this anti-D is going to attack only the red blood cells from the fetus that possess this epitope, this D antigen. It will not attack the mother cells. No, it's going to attack only those cells that have crossed from the fetus to the maternal saturation. That's where its essence is and its magic is. It is highly specific antibodies against a single antigenic epitope produced by the colon of a single hybrid cell formed in the laboratory by the fusion process. So I've said that this is a monoclonal anti-D immunoglobulin, which is highly specific against the D epitope on the fetal red blood cells. So that's the process for manufacturing. I don't think we need it, but just maybe to get to know how it is done. Well, you have the myeloma cell culture, then you have the human D, you have the hyperimmunized human donor forming the human D, producing lymphocytes, then you have the myeloma cells, then you fuse them, forming the human anti-D processing hybrid myeloma, hybridoma. Then you have the cell culture, then you have the purification process to leave you with the anti-D immunoglobulin. In this case, the Rocklon, which we normally use, which has been tested and proven very efficient, very potent. And those are the advantages of being a monoclonal immunoglobulin. It is specificity, uniformity, and consistency being high, and then safety from emerging viruses. So it is very safe for our patients. Then the efficacy, like you see, the rate of red cell clearance, the ability of Rocklon to clear the D positive red blood cells through the spleen, because it has been noted that this clearance occurs within 3 hours of administration of this drug. So after 3 hours like this, these tagged blood cells, or red blood cells that we are looking for in the maternal saturation are eliminated or cleared from using the spleen within 3 hours. So it's quite potent. Other advantages are no donor pool involved, no risk of emerging viruses, no lot-to-lot variation, unlimited supply. I think it is everywhere now. And most of the pharmacies have reduced the price from, I think before it used to be 280, some would sell 300, but now have places where it goes for as low as 220, because I've been using it a lot of recent, 220, 30 there. And also in the hospital, you have been stocking. You find that in a quarter, we can have like 3 or 4, though we have asked government to increase the supply to at least 5 or 6 for starters. But we have been receiving 2, 3, sometimes 1, and they are really short on demand, very high on demand, and so the supply does not sustain anything. Then consistency and uniformity, which is assured. Oh, sorry. So we have the prevention of HDN, that's hemolytic disease of a newborn on a neonate, antenatal prophylaxis of HDN, termination of pregnancy, miscarriage, abdominal trauma. So these are indications or conditions which are going to lead you to think of giving this drug. Extracephalic version, you're trying to turn a breech into a cephalic presentation. So by doing that, you may easily induce retroplacental bleeding. And if there is that possibility, then you're safer to give that drug, because you may not be in position to measure how much of the fetal-maternal hemorrhage has occurred. Then you have in ectopic pregnancies, because we know these are bleeding conditions, bleeding in early pregnancy, threatened abortion. So those qualify for us to think about giving this anti-D, where we have mothers who are anti-D negative or who don't have the D antigen on their cells. So we need to give so that at least we are sure we are protecting them not to mount an exaggerated response in the next or subsequent pregnancies that may follow. So we know that 20 micrograms of the anti-D will neutralize 1 ml of RH positive cells or 2 ml of positive blood. Then you say that the 300 micrograms we normally give, they take out 15 ml of the RH positive red blood cells in the maternal saturation, or they'll take out 30 ml of positive blood. That's what we talked about before. So that's the formula. So you can use that to calculate where you have done maybe the rosette testing, then you go for the Kell-Back test, and you're sure that this is the amount which has crossed. Then you may choose this formula to help you give the appropriate dose. But in a nutshell, people have been giving 300 micrograms, because I've seen people say, this one just give only 1. And it has been working, so we need to maintain that. Then we look at the guidelines. We have the FIGO ICM guidelines for preventing Rhesus disease, a call to action, and that was when? That is August. It was received in August 2020. We see here they're saying the introduction of anti-RHD immunoglobulin more than 50 years ago has resulted in only a 50% decrease in Rhesus disease globally owing to low uptake this prophylactic approach. The International Federation of Gynecology and Obstetricians, International Confederation of Midwives, Worldwide Initiative for Rhesus Disease Eradication have reviewed current evidence regarding the utility of anti-Rhesus factor D immunoglobulin, taking into account the effectiveness anti-RHD, and then the new guidelines propose adjusting the dose for different indications and prioritizing its administration by indication. That's that guideline. That's what it says about the anti. Then we have this where we think of the high priority, determine the maternal RH factor, preferably in early pregnancy. For RHD negative women, determine the RH factor for the newborn from umbilical cord blood, chorecentesis. And then you have the administering of the anti-RHD immunoglobulin within 72 hours of delivery, women with RD negative or to RD positive newborn babies, unless those who have already sensitized, that one may not need to administer, because even if you do, there's nothing much it's going to do. So this drug is given in mothers who have not yet gotten a chance to get allo immunized. Once they start allo immunization, that's formation of antibodies to this. It is a waste of time. Your anti-D will not help. Why it's going to help you is when they have noticed started forming the antibodies. That is, or when they have noticed started immunization. But where mothers are just sensitizing, it is okay. There it will help you work, because it's going to remove the factors that are bringing the sensitization. Then you're going to use a dose of 500 international units, that's 100 micrograms of anti-RHD immunoglobulin, if affordable and with sufficient supply. We can give 1,500 international units, that's 300 micrograms may be given, as is common in high-income countries. At least I'm glad that also you are trying to give the 300 micrograms here. The intramuscular route is as effective as the intravenous route, because most of our drug has been coming for as an intramuscular route, IM. We normally give it IM. So that's according to that guideline. Then the middle priority, we have routine anti-RHD prophylaxis during pregnancy. That's why you're going to give at 28 to 34 weeks. Then you have the anti-Rhesus immunoglobulin prophylaxis, which is 500 units or 100 micrograms after surgical abortion or ectopic pregnancy for all gestation ages, or after spontaneous medical abortion or miscarriage after 10 weeks. Then you have anti-RHD prophylaxis after bleeding, abdominal trauma in pregnancy, and or fetal death, that is 500 or 1,500 insertion units, or 100 or 300 micrograms during the second or third trimester. But remember, the Kellogg test can be used to estimate the optimal dose. But in a situation where you're not able to do it, you may give those doses blindly. And then low priority, anti-RHD prophylaxis after amniocentesis. If maybe you're doing a DNA analysis where you're going to go through these membranes to tap on maybe the amniotic fluid and suspect there could be some bleeding. So you might give it chronic villus sampling or external cephalic version. You can give 500 international units, which is equivalent to 100 micrograms of the drug. When you look at that Journal of Obstetrics and Gynecology of Eastern and Central Africa, leaders in obstetrics practice from various African countries met towards the end of last year to discuss the unmet need to address the burden of Rhesus disease. They noted that despite being entirely preventable, Rhesus disease was identified as one of the roadblocks to achieving maternal universal health coverage. The team recommended all stakeholders to facilitate access to anti-D immunoglobulin and screening tools for widespread screening and treatment. Then look, if we are to consider Ministry of Health, and what they say here, we have the standard treatment guidelines and national essential medicines list. That's for Tanzania, where they have recommended anti-D also to be given. For example, for them, they are giving antepartum. That is, if the mother is Rhesus negative, give anti-D immunoglobulin 300 micrograms within 70 hours of delivery, antepartum, or you can give between 28 and 30 weeks, the same dose. Then abortion, Rhesus or negative mother, give anti-D 100 micrograms, that is 500 tertiary units, within 72 hours of the abortion. Then ours says what? Here it says, and if you were to look at the essential maternal and the newborn clinical care guidelines for Uganda, there is just a year back. It says that almost 2 years ago, it says investigations to ensure the mother is fit for labor, that is blood hemoglobin level, blood grouping and cross matching, and Rhesus factor. So you have to screen it here. Then they're saying gestation age between 26 to 37 weeks. They have recommended to give this immunoglobulin to those mothers who are Rhesus negative. So they recommend us to give this immunoglobulin at 26 to 37 weeks. So we have been giving at around 28. Most people give between 27 and 28, and then others repeat postpartum. Then others also can repeat at around 36 weeks. I've seen people give at around 34, 36, but most people get 2 doses at 27, 28, and then they receive after the delivery of the baby. That's what I've seen common practice here. So in conclusion, we know that RH isotominization is a real problem and real efforts needs to be made to mitigate its impact. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of the newborn remain. That one we know, at least it is quite a common condition, hydrops fetalis. And once it happens, this baby has to lose life. It is quite, the mortality is high, over 50%. So it is incompatible with life. They normally live for the first 2-3 hours, and then they will succumb. Every woman of childbearing age should have a blood group and RH types done at first contact. And we are promoting this in our pre-conceptual clinics. The pre-conceptual concept is quite new, but it has been around for some time, though people have just started picking it up. But these are tests that we have to do in that clinic. Before you think of conceiving, please get to know your blood group, your RH factor, whether you're positive or negative. It is very important because they will help to shape who you select to have a child with or something like that, so that you don't have to go through this. Then you have to obtain the ABO, RH types for husbands of women found to be RH negative. Even today, a larger number of women who should be protected against RH immunizations are not receiving this. So like we said, as alluded to earlier, one of the main principles for the management of this, what you can take home, the RH incompatibility is the prevention of maternal sensitization. Once there's allo immunization, it is too late. We are wasting the drug. So thank you.
Wow, this is so insightful, Doctor. This is so important. It was so timely. Members who are online, this presentation was prepared since last year, and we are happy that the whole of this month we have been discussing obstetrics and we have been discussing gynecological issues. And at this juncture, I will pick some questions in the remaining time, then we shall have Doctor to answer. Before I have Stephen to ask the question, let me pick this question from Moses Nassim, who say thank you for the presentation. Then he notes that I think he has a patient who is a gravida 5, para 2+2, and the lady is at 8 weeks of amenorrhea, blood group A, Rhesus D, and the lady has never got an anti-D on any of the previous pregnancies. She lost the most recent 2 pregnancies. How would she be managed on this current pregnancy? That's the first question, Doctor. You would prepare to answer it. Then I will pick only one other question. Then you answer those. This one is from Ouma Robert. At what gestation age do we give prophylaxis for HDN, and maybe the presentations of HDN? Then lastly, the third question, before you answer the 3 questions, Doctor, it says from Oyaka Alan, say thanks for the presentation. Please expound on the situation to offer anti-D besides the dosage at 28 weeks and within 72 hours of delivery, especially somebody who most likely is antigen sensitized with evidence of miscarriage. I think, Doctor, you could pick up those 3 as we find others.
Thank you, Desmond. And the first question says, there's been a mother, I think it's a para 5, who has lost, has been RH negative, has lost the last 2 pregnancies, but has been able to have the children before, not so? So we said in such a scenario, remember, there's that aspect of the FMH, that's the fetal maternal hemorrhage. Maybe it used to be occult, like that the volume that was being exchanged was not enough to warrant what? To warrant allo immunization in the mother. However, maybe on the last pregnancy that came out alive, that's the 5th pregnancy, maybe it was significant. And since this mother has not been getting the anti-D, so he must have formed the antibodies against the RH positive fetuses. So what does that mean? That now maybe these subsequent pregnancies that are coming and are being lost is because of the incompatibility. So the reaction comes in early because now the mother has mounted significant what? Antibodies, so they don't allow pregnancies to proceed. So in such a scenario, there's nothing you're going to do because this mother has formed the antibodies. You get. So a mere noticing of an RH positive fetus, it is finished. It can't survive. There is no more chance to tolerate because now is able, the immune system is able to pick it up as early as possible. And that's why they can never get pregnant. They're always losing repetitive abortions, 3 months, 2 months, they are coming out. They had the opportunity then, but then something went amiss in the middle and she was not helped. If she had received these antibodies from the previous pregnancies, that opportunity of them alloimmunizing will not have set in. But once they alloimmunize, it is a waste of time. The drug will not help. So in that aspect, I don't think you're going to help this patient by writing anti-D. To be a waste of money. And the second question is, what gestation do we give anti-D? And then said a presentation of HDN. Am I right?
Yes, doctor.
Yeah, what gestation? So in Uganda, we are giving at 28 or 27 to 29. There, I've seen most people are giving that. Because now the guidelines are recommending 26 to 37 weeks. Then you're also giving postpartum within the first 72 hours. But remember, there are other conditions. For example, if this mother who is a Rhesus D negative, for example, maybe was involved in an accident, fell off a border, and you're thinking there could be some placenta rupture setting in, you do a scan, it is confirmed, please give her the anti-D. Don't wait for 27 or 28 weeks to give it. You give it early so that you're preventing the slightest chance that could be there for this mother to alloimmunize, because you don't want them to go to alloimmunization, because that is a no-reverse situation. We want them to stop at sensitization, trying to sensitize. Why? Because that's when the drug is able to wipe out all these positive cells that have crossed from the fetus to the maternal saturation during sensitization. But when they alloimmunize, they form the antibodies against these positive red blood cells that have crossed, then it is late. So if you have early first trimester bleeding in a mother whom you did your test preconceptual and you found that this mother is RH negative, and then they are bleeding early, please, threatened abortion, they are bleeding, they are doing this, please, they have had an abortion, give them an ectopic pregnancy, don't wait for 27 weeks.
Okay. Thank you so much. Thank you, doctor.
Then the symptoms and signs of HDN. Remember this hemolytic disease of the newborn, we have it's a spectra. We have the simple one, which is just the hemolytic anemia. Then the serious one, which is going to end up in hydrops fetalis, where it is like severe anemia, where you have the fetal heart becomes like, you will have pericardial effusion around the fetal heart. You will have pulmonary effusion in the baby's chest. Then you'll have ascites. The abdomen will be distended. When it is born, even you press the abdomen, it is hard. It is not soft. Because now these will be signs of severe hemolysis. So these will be what you can find as all these hydrops fetalis. Then the third question is about, the third question was, Desmond, can you repeat it for me? Hello? Hello?
Okay, I'm finding the question.
Yeah, it was about,
at what age do we give the prophylaxis of HDN? I think that was my last question.
I've just answered it, because the age is not specific, that this is the age you should give. However, if it is ideal, we are giving between 26 to 37 weeks. That's the recommendation from our Ministry of Health. But remember, these patients can come in at 20 weeks, maybe with the trauma, and they have to get. But in the ideal setting, should be between 26 to 27 to 37 weeks. And then postpartum also, on the third day, we are able to give. Because we said, if you give at around 26 weeks or 27 weeks, 28, 20, 29 weeks, we know that that protection is for 12 weeks. So meaning by giving around the delivery, you're boosting the protection further. That is postpartum. You're adding more protection to this mother. I hope I'm clear on that.
Yes,
That's
thank
why
you
we
so
are
much.
giving at least 2 cycles. But ideally, if somebody would afford, could even get like 3. But because of man or what, maybe that's why we are giving 2. Because if you give around 28 weeks plus 12 weeks, that's almost what? 40 weeks. So at delivery now, we have to give another shot to try to protect this mother from the exposed blood that could have crossed during the process of parturition. I hope I'm clear on that.
Yes, doctor, you're very clear. Let me have Mariam expound on the point of Rhesus before we get Dr. Chwan and Stephen ask their questions. Just Mariam.
Hello, good evening to you all.
Good evening,
Thank you for
Mariam.
attending this session. Dr. Ben, I appreciate you for your presentation. It was really an educative session that I believe most of us have gotten good information from it. My name is Mariam Nakamia. I'm a member from Barat Serums and Vaccines. On this platform, I attended with a number of colleagues from the same company. We are the distributors of the drug called Rocklon anti-D. I would like to welcome my colleague, Mr. Pademkwaya, to enlighten more about anti-D and the necessary information about the company.
Yeah, thanks, Mariam.
Mr. Paddy?
Yeah, thank you, Mariam. Good evening, colleagues. I would also like to say we are online with Mr. Deepak Puri, our group country head, and the man behind the work of fighting Rhesus disease in Uganda for the last 8 years. Mr. Deepak, if you're online, please would you unmute and greet the colleagues and then make your communication.
Thanks, Paddy. Thank you so much. I'm so delighted, in fact, the way the people have taken this presentation. In fact, first of all, I'd really like to thank Dr. Mondo. The way he presented so beautifully each and every point. So thank you so much for the beautiful presentation. I really thank you, in fact. And in fact, I'd like to thank, the health forum also, Busoga Health Forum, for giving us an opportunity. Because this particular topic is very, very important for us. I have personally have seen it, and specifically in upcountry locations. Many times I have seen, because of just simple blood test, people are not aware that why these abortions and miscarriages are happening. So this is in fact a very good, kind of an initiative have been started by this health forum. It gives us a platform also. And the way the doctor took up each and every point, that was tremendously, thank you so much. In fact, I would like to tell you that we are the only company here who are marketing these kind of biotechnological products. Specifically, Roclone is one of them. And talking about this anti-D, in fact, just I want to tell you, doctor took each and every point. But one thing which is important, from our side, for the health professional is that please tell your patient or maybe to check their blood group. Because sometimes just for simple reason, because her blood, if she is a rhesus factor, she may not be knowing that why she's becoming, why the abortions are happening again and again. And she's losing that particular opportunity of becoming, to deliver the baby. So that is very, very important. If we don't have, the blood test happening in the premises, in the hospital, people who can afford, because this simple blood test is just may not going to cost more than 15,000, even 10,000 at some of our places. But that is a one-time test only. They don't need to go for the blood test for every time. Once the lady comes to know her blood grouping, that is a one single test for the entire life. And then it's become very easy that yes, she knows the blood group, or we know the blood group, and it is easy for us to diagnose it in a proper way. As doctor says, when the lady becomes, when there is alum immunization has happened, it's very difficult. When no drug will going to work, and then then the lady comes into the social stigma also. The people thinks that she may not can deliver. So to avoid these kind of a problems, this is very, very important that we inform, we educate the people, the patient, just to have a blood group. This is very important. In fact, we're going to work, we are planning to work along with Ministry of Health also very soon. We are starting one of a pilot project where we are distributing, free blood samples, blood grouping samples to do the test for this rhesus factor. But that is quite early stage. But yes, 6 months, 7 months down the line, we'll have a plan to start it in the regional centers also. So I'm not going to take much of a time, but thank you, Dr. Mondo, the way you presented. Thank you so much from our side. And from my BSV family, right now we are the many people are there in the team. I really, thank each one of you for giving us your valuable time on this forum. Thank you so much.
Thank you, Mr. Deepak. Mr. Kasvante, I wanted to share something on universal eradication of Rhesus disease, but sharing the screen has been disabled from your end. Mr. Deepak, you would like to touch on the Cure project?
No. I am not taking. If you can take it, yeah.
Okay. Mr. Kasvante, I think I cannot share the screen, but colleagues.
Kindly share and a bit be brief because you have more questions to answer.
Come again?
Kindly share your screen now and a little bit brief such that we have more questions answered in the next minute.
Now I'm trying to share, but it says the host has
kindly share now.
Okay. Okay. It is not going, but maybe I'll talk through it just in a minute. Ladies and gentlemen, Rhesus disease in many of the developed countries has been eliminated.
Sure.
Oh, yeah. Now it has come. Okay. Okay. Are you able to see the screen now?
Yes, please.
Yeah. So we are having a project from the House of BSV for Consortium of Universal Rhesus Disease Elimination. Just to give an update, in many of the developed countries, Rhesus disease has been eliminated systemically. It has been eliminated systemically. But in Africa, Eastern Europe, and many parts of Asia, Rhesus disease is still a significant problem. What we would like to echo to the team is that this is a disease which can be completely eliminated if we work together and do the blood grouping as Mr. Deepak has said, and provide support and knowledge to the community. Many people get miscarriages, they abort their babies and no blood grouping is done and isomimization happens. But if we work together, this is a disease which, first of all, it's a good thing. This is something which can be eliminated. We have a Curie project. This is a certification program from BSV in partnership with the ICC Record, Royal College of Obstetrics and Gynecology. We are going to share the link with you. Mr. Kasvante, I think we shall share with you, where members will be able to go through the current updates in management of Rhesus disease. As you can see on the screen, if I start from here, this is I'm logging into the platform. When you get the link, you can log into the platform, and then you are going to go through a 2 modules of lectures. You'll be able to write a small assessment via multiple choice questions, and then you can get an international coveted, highly sought after certificate from ICC Royal College of Obstetrics and Gynecology of the UK. With updates of universal eradication of Rhesus disease. So the course is led by international acclaimed teachers and doctors. Dr. Chimea Ratha, you will see the first module would be compatibility and overview, pathogenesis and disease burden. And then you will see prevention of Rhesus disease by Dr. Parr. Okay. That is the first module. And the second module, I think this is where many questions came through. Here you'll learn recent updates of isoimmunization, the presentation and management if you're having a patient who is already isoimmunized. So Dr. Ghosh is going to, these are video-based, you'll see, you'll be watching the videos over and over, and then you'll be able to get many answers to the questions which you might have. And then the Curie project will be expounded by Dr. Basab. So this is a project which we are coming through. Get the certificate, get through the study and update. Mariam is going to share the link as well to the group, and then you can go through. I'm sharing with you what you should expect. So here I'm already inside, and if I click on the course, Rhesus disease, you can see the details which are there. You can click here and enroll. So the courses are already here. And the good thing with Curie is going to be free of charge. You are going to get the certificate free of charge and the knowledge free of charge. And together, if we work together, we can eliminate Rhesus disease. So please take advantage of this platform and this initiative from BSV to ensure that you share with as many colleagues as possible so that we work together to eliminate Rhesus disease. Mr. Kasvante, thank you very much.
All right, thank you so much, Tim. Thank you, Mariam. Thank you, Paddy, for that insightful expounding on how members can get knowledge about Rhesus disease. Let me have Dr. Pontian ask the question.
Thank you very much, Dr. Mondo and all the other presenters. I was on and off, but let me hope I'm not going to repeat questions which were asked already. Dr. Mondo, is there any intervention in utero to prevent the very bad complications of isoimmunization? That's the first question. Second question, if a woman comes up with the isoimmunization and she has lost the pregnancy and she thinks she needs to try, is there a test that can predict that you don't even bother to try conception because it will not be there anyway? And then the last one, these women, if they have no hopes, is there a possibility of ovum donation in the cases of IVF so that surrogacy can take place, or even the ovum this time during the process of harvesting will be affected? Thank you so much.
Dr. Mondo, could you answer those three questions before I pick others?
Thank you, Dr. Poshan. To start with, the question about isoimmunization, whether it could be reversed, the effects. For example, this patient is already alloimmunized, has formed antibodies against Rhesus positive fetuses. Can we reverse that? I don't think there is a drug for that. It's not available. That's why we fight so hard to make sure this patient does not go to alloimmunization. If we screen, like the previous presenters have been saying, screening is the key to eradicating RH incompatibility. The only method or the only advice that will be left is maybe to change of pattern. Because we know if this woman is RH negative and ends up with the RH negative man, they'll have their baby safe. There will be no need for anything. Because now, but once RH positive father, there's a 50% chance of RH positive baby who cannot survive the harsh condition in utero. I don't think there's a drug we are going to give for that. Then the second question was the test to know whether someone has isoimmunized, and you advise them, please don't disturb yourself carrying this pregnancy. Like we said, the rosetting and the Kelleback test, the rosetting is screening. It's a screening test we use. Once it is positive, then you go to the Kelly-Back test. The Kelly-Back test is for measuring how much of the fetal maternal hemorrhage has occurred and to guide you on the right dose of the drug to give so that you don't underdose the patient to end up alloimmunizing and also not to overdose the patient. So the test to know that now this patient has formed the antibodies against other positive fetuses. Most of the time, the conceptors, for example, if maybe there's an abortion and it has happened, we are meant to take those products of conception for histology. But many a time, most of us, once we do the evaluation, we just we throw away these things just like that without subjecting them to further testing, where they're able to tell us this was maybe following Rhesus incompatibility, or this was this, because there'll be those signs. There'll be those signs of maybe there was hemolytic anemia in this embryo. Such things would be missed, and those could guide us to that this patient already formed the antibodies to the fetuses that are positive. Hepatitis test, they're there, but in Uganda we are not able to do them. But there are other countries in the advanced world where they're able to do these antibody tests. But here we should be using more of the histology.
Okay, thank you so much, Doctor.
Then I was talking about surrogacy. Surrogacy is where somebody is going to donate, is going to accept to carry someone's pregnancy. I have my wife, but maybe can't conceive, or we can't have a baby naturally, but then maybe we get her ovum, it's fertilized, then we implant in someone who carry for us a baby. I think that is okay. It does not really matter much, as long as this ova, for example, the carrier, the one who's going to carry the Rhesus, she has to know, we have to know the Rhesus factor, whether she's positive or negative. Because if it's negative, it will more or less be the same thing. If the man who has fertilized that egg, they have used the sperms of the man to fertilize the egg, and that one will be positive. There's a 50% chance that this baby will be positive. So if the mother who is a surrogate is going to be Rh negative, I don't think we'll have changed much. But if it's positive on a positive father, then that is okay. No problem with that. I don't know if I've answered this question right.
I think Dr. Pontian, you're satisfied.
I'm very okay. Thank you so much.
Okay, that's beautiful.
You're welcome.
Because of time, let me have Stephen Jingo ask your questions, and then that will be our last.
Thank you so much. Mine is not a question, but I think there are some things that need to come out strongly. Number one, for mothers that have delivered before and they are Rhesus negative, before you give the anti-D, indirect Kumbus test is a must. It is non-negotiable, because once it is positive, management is different, and once it is negative, that's when you can give. Now, once it is positive, management now goes into MFM. I don't know whether we have some MFM specialists on the call, but you manage, you monitor the mother. Usually the cutoff for the titers is 1 in 16. There is a clear guideline on how to manage those titers. For the fetus, middle cerebral artery indices, okay? The only challenge I have here is that sometimes these mothers who are already isoimmunized are referred late or come to the hospital very late when the baby has ascites or they already have anemia, and it is too late. But otherwise, if you catch them early when you are monitoring the mother with the titers and also the baby in the fetus in utero, I mean, there are so many things you can do. Intrauterine transfusion is possible. I don't know whether we have some MFM specialists on the call, and I don't know whether we can do some intrauterine transfusion in Uganda, but that is completely a different thing altogether. I think now Busoga Health Forum needs to organize how do we manage somebody who's already isoimmunized, because the guideline is clear. MFM can do something about it. Now, when to give anti-D. I think that shouldn't be a problem, but we should understand the science, whether it is between 28 to 32, or now I've just heard that for Uganda, it's 26 to 37. The issue is, once you give between 28 to 32, or between 26 to 37, and then also you give within 72 hours after delivery, the science is that once you've given those 2 doses, you have less than 1% chances of getting the ISO immunization. Are we together? Because the anti-D half-life is around 3 months. So whether it is between 28 to 32 or between 26 to 37, now this is a new thing I didn't know about it. And it doesn't matter so long as you've given 2 doses, and then the last one being within 72 hours within delivery, then you have less than 1% chances of getting ISO immunized, because the anti-D half-life is around 3 months. Now, there's this other question. If the mother is negative, the father is Rhesus negative, they can only get a Rhesus negative baby. But that is only true if the father is the true father to the baby. Of late, I've been watching Agatari Konfufu. So meaning that people should be careful. Kindly, this only happens because the father is the true father if they are both negative, because the Rhesus D, that D factor is the autosomal dominant. So meaning that if the mother is negative, if the father is negative, they can only get a negative baby. But that is only true if the father is the true father to the child. Otherwise, with these Gatari Konfufu videos on everywhere, people should be careful. Thank you so much.
Okay, thank you so much, Stephen. And I think by your submission, you've answered the Herman's question and also answered Opio's concern. And I will not pick that. Right now, allow me to come to the end of this webinar. I know it's very interesting. Many people may have more questions, but because of time, we shall look forward to having another CME in the same line. Right now, I will invite Professor Peter Woiswa to give the closing remarks and close this session. Thank you so much.
Wow, this has been very interesting. If the father is the true father, which is super interesting. And I think there are many situations where the so-called father is not a father. So, which you might never know. But thank you so much, Dr. Mondo, for this very interesting presentation. Really, a good way to do science, because people, we are generally ignorant on these simple things. Women having repeated abortions, and we are not investigating them, and that abortions are very common, having repeated stillbirth and more. And I think for me, this talks about the importance of being systematic. And like somebody say that these problems are being resolved in the West because of being systematic. So thank you so much for this presentation. I think you need to repeat it several times, even perhaps simplify it, and even think about what way can people like nurses, midwives, medical officers, clinical officers be able to know, and how we can introduce these simple guidelines in the practice, because then they will be so important. So thank you so much for this. And with this, Dr. Mondo, and of course, we know your other work you do in the region, we give you a simple certificate of appreciation. Thank you so much, Doctor.
Welcome.
Next, Samuel Kaswante. Of course, Kaswante is a true champion in the region. Sometimes he's also writing and talking a lot, but doing so scientifically. So I like his arguments. Samuel, please receive this certificate of appreciation. And I thank the colleagues who have joined, and some of the private sector who also joined. Please, you are invited to repeat these presentations on Busoga Health Forum, and to come and engage, and perhaps also partner with us in rolling out these efforts. Busoga Forum does all this work with very little support, basically subscription of a few people who support. So invite members, please join the Busoga Forum, make your contribution, make your subscription, but also you can donate. Thank you so much. And I would like also to thank Benjamin for always being there and coordinating this. Thank you so much, everybody. Let's see you next Friday at 8 p.m. Have a wonderful weekend. God bless. Bye-bye.